Start this morning with a general overview of the research of our center, of our research portfolio. And some of the studies that I'm going to be mentioning briefly we'll be going into a little bit more detail about, but I wanted to just sort of give you sort of a broad idea of the work that we're doing. Our two centers, the center here at UTEP and our center in Miami, have a tremendous number of points of commonality. And at the same time, really great opportunities in terms of having two unique Hispanic populations that are different from each other and really lend themselves for replication studies or multi-site studies. So I wanted to give you all sort of an overview of what we do so that you get a sense of the kinds of things that you might be interested in collaborating with us on and areas where we can be of mutually beneficial in terms of our expertise and our knowledge, et cetera. So as Elias mentioned, we are a P60 center funded by the NIH, and if you see our banner, you might recognize the handsome guy at the bottom there as somebody that you know, Elias, who's been here, who was with us when we started the center and has been an integral part of the center, and actually an integral part of the research I was doing even before the center. So our center is focused on 4 health conditions that we really see as a constellation of health conditions that disproportionately affect Hispanics and other minority groups. And those include HIV and other sexually transmitted infections, substance abuse, family and intimate partner violence, and co-occurring mental health especially, and to some extent physical health conditions. The populations that we work with are the ethnic minority groups that are highly represented in Miami and the South Florida area. Which has been predominantly Hispanics, but we have expanded in the last few years to work with African American groups and Caribbean American groups, as those are also groups that are highly represented in Miami, and that also share some of the same health disparities and some of the same common root causes and root sort of risk factors for these health conditions. We also work with sexual minority groups, and particularly with men who have sex with men. And we have been working in international collaborations with the Caribbean and with Latin America. We have also at the University of Miami School of Nursing a PAHO Center, Pan American Health Organization Center. And through the connections of that center, we have availability and connections with a large network of centers in Latin America. How are we doing? I know I'm messing up your video, sorry. What if I do this? Is that better? All right, go ahead. Okay, so I wanted to show you sort of an organizational chart. I hope this is visible to you. This is an organizational chart that's based on the resubmission that we just did. You all just did a resubmission of your P20. We just did a resubmission of our P60. Congratulations to all of us who survived this process. And what I have up here is the cores that we have proposed. The only thing that's new is the community engagement and dissemination core. So we have 3 cores, a research core, which I had, a research training and education core, and a community engagement, dissemination, and implementation core. Our PI is our Dean of the School of Nursing, Nena Paragallo, and I'm the co-PI, and then we have a very strong administrative core that's headed up by Marina Alvarez. We have a scientific advisory board, which includes about 12 members who are highly recognized, nationally recognized scientists from around the country and from Puerto Rico. And we have a group of associated faculty that equals about 24 people in addition to the people who are head up the course. The associated faculty that we have are from the School of Nursing primarily, but also from the School of Medicine and from the School of Education. So we really do have a truly interdisciplinary center, and our school is truly interdisciplinary. Dr. DeSantis and Dr. Cianelli are both nurses. I'm a psychologist. Our dean is a nurse, but also has a background in a doctorate in public health. Dr. Cianelli has an MPH. So we do have, and we have a a medical sociologist has joined us recently. So we have rounded out the interdisciplinary team of people that we have in our group. Oh, good, thank you. Just to give you a brief idea of what each of the cores does, the research core, basically, I'm going to be showing you a lot of different studies that we have in our center. And some of the studies are directly funded by the P60 grants. So we have 2 randomized trials, and we've had a pilot studies program that have been funded. But to me, the more important part of what the P60 provides is, support for building an infrastructure that can assist studies that are funded through other mechanisms, for example, through NIH or through internal mechanisms, but that we can provide support to those studies in terms of data collection, in terms of IRB consultation, in terms of biostatistics advice, data management, et cetera, so that the work can be done more efficiently, so that the investigators can really focus more on the science and can have the luxury of having help with those other things that really take up a huge amount of time and effort. And when we do it across many studies, then really there's an efficiency and a way of doing it in a way that has better quality control, et cetera. So what we do in the research core is we have the studies, and we also provide the infrastructure platform for new studies. The training core has been focused primarily up to now in nursing, undergraduate and PhD. We have a PhD program in nursing. We have undergraduate programs in nursing. We have a BSN, we have a traditional BSN and an accelerated BSN. And a new area that we've really developed in the course of having the P60 is undergraduate studies in public health. So as of the last couple of months, we actually have a major in public health, which has attracted a lot of students. Students are really interested, and we're hoping that sometime probably in the next year that we'll turn it into an articulated bachelor's of public health and master's of public health program in collaboration with the Department of Public Health and Epidemiology that's in our School of Medicine that does have existing MPH and PhD programs. We're also working very closely with the School of Education. The School of Education has a counseling psychology program, and the counseling students, we have a long tradition in terms of our investigators of working with those students, and now we're really forming a much closer collaboration and hopefully forming actually an interdisciplinary PhD that's going to be focused entirely on health disparities. That'll be a collaboration between the School of Education and School of Nursing. And then the community and core is something that I mentioned is new, and it's proposed and hopefully will be funded and we will have it. When we originally had the original P60 grant, the RFA specifically said that there should not be a community core, that they were not interested in community, that they were interested specifically in research. So we did not have a community core. It's very interesting to see how things have evolved in thinking over at NIH, because in the RFA that came out this year that we responded to, the community core was required. And so it really shows that the issue of working together with the community has been recognized, at least at the NIMHD, as something that's vital to the to addressing health disparities. So I think that's a very positive thing. So we have certain themes. We have our health foci that I mentioned, which were HIV, intimate partner violence, substance abuse, co-occurring conditions. But we also have certain themes that we tend to follow in basically every study that we do. One of those themes is that we're interested in development and the evaluation and the dissemination of culturally tailored interventions. Interventions that, as I'll mention in a minute, were either developed specifically for a minority group or that have been adapted for that group. So that's an important theme. Another important theme for us is that we are interested in addressing multiple health conditions. As you'll see in our presentations, all the studies that we do are really addressing more than one condition. They're not only focused on HIV, they'll be focused on HIV and mental health and substance abuse, for example, or not only prevention of HIV, but prevention of intimate partner violence. And the reason for that is because our conceptual framework is that these conditions have common underlying roots. And what we're trying to address is those root causes, and to address and to strengthen the underlying protective factors that really address multiple conditions. And so that if we can address multiple conditions at the same time, it's much more efficient and it's much more powerful in terms of the impact that it can have on addressing health disparities. Finally, oh well, not finally, but another area that's very important to us is
culturally competent, culturally tailored methodologies for how we do our research, and I'll get a little bit into those things in a minute. The other one that's extremely important to us, and from what I see here is also extremely important here as well, is really investing to a tremendous amount in the future of health disparities research by really mentoring and nurturing and doing as much as we can to nurture the next generation of health disparities researchers. And it's wonderful to see around the room and to have met this morning people who are getting started, who are getting their PhDs, who are doing research that really has tremendous impact and potential for impact down the line, you know, so that some of us can retire, you know, at some point, and there's a next generation that's going to be doing this research. So that's extremely important to us. And finally, as I mentioned, and again, this is something that I see as very, very true here as well, is the idea of interdisciplinary team science, that all of these problems require an approach that considers many different facets and requires a collaboration of different disciplines. So these are our themes that we have really across all of our studies. So as I mentioned, culturally tailored interventions is really hugely important to us. And the issue is that in a lot of the areas that we've worked in, there are existing empirically supported interventions. But by and large, they've been tested on general populations. And in these studies, there haven't been sufficient subgroups to do meaningful analyses to see if these interventions really work with these groups. So that you might have a study that has 20 Latinos, it has 200 participants, 300 participants, has 20 Latinos. You can't really do a meaningful analysis to know if it's going to work for that group. And the reality is that we know that when it comes to behavioral interventions, when it comes to behavior change, there are culturally related values, behaviors, experiences, things that really do need to be taken into consideration. And there's a good chance that something that was developed, a behavioral intervention that was developed for a broad population, really might not have the impact that it needs to have on a specific minority group. There basically are, there are different levels. There's a large literature out there on culturally tailored interventions. Our colleagues in the University of Puerto Rico, Guillermo Bernal, our colleagues at the University of Miami, across the country in Boston and here as well, have done work in terms of culturally tailored interventions. And we can think of culturally tailored interventions as sort of lying on sort of three levels. The first level is one that a lot of people think about out in the field, especially in the field of psychology, and that's my discipline of psychology, is the idea that to make something culturally competent, really what you need to do is make sure that you're using culturally competent interventionists, right? So people who are either from that culture themselves and sort of understand the nuances and the special needs and the special strengths and the kinds of things to watch out for and the kinds of things to address. And that if you have culturally competent interventionists, that in itself makes for a culturally competent intervention. And there's a lot of legitimacy to that, and certainly there's been a good amount of research done out in California and Arizona, et cetera, showing that if people are offered an intervention in a site, for example, that's culturally friendly, where the staff speak their language, who are similar to them, then people are more comfortable and they tend to do better, they tend to engage, et cetera. The next level is to take an intervention that has been empirically validated or empirically supported for a larger population and say, okay, how does it need to be adapted? So this looks like a good intervention, but how do we need to adapt it to make it work for this particular group? And some of the work that we do has focused on that. It's taken interventions that were made for the broad population, and we've figured out through focus groups, et cetera, how to adapt it for our population. We test it out, and then we can put it out there for that group. So that's level 2. And then the third level, which is actually probably the majority of the work that we've done, is interventions that were developed from ground zero for that particular group. So the CEPA intervention that Dr. Cianelli is going to be talking about a little later was developed specifically for Latino women. And with them in mind from the beginning. It wasn't something that was created for somebody else and then adapted. It was created originally with Latina women in mind. In terms of addressing multiple health conditions, as I mentioned, our conceptual framework really has been based on the idea, and we've actually done some empirical work that have shown that a lot of the different health conditions that we work in do have are common latent variable. They load on a common measure. They're a common construct. And these things are really inextricable. It's not just that they're comorbid conditions, it's really that they're inextricably tied from each other. And they're inextricably tied in the sense that they have a common substrate underneath them in terms of what is causing them and what is leading to this risk. And so we see this common sort of underlying variable as having to do with socioeconomic disadvantage, acculturation stress, acculturation factors, and cultural factors and values, et cetera, that are both protective and risk factors at the same time. And a little later I'm going to be talking about a program of research on intimate partner violence where the participants really identified this. They called it a double, our culture as a double-edged sword. So it has its the same thing can be protective and also problematic. And so this conceptual framework of this, that we're trying to address these underlying root causes, is really what helps us develop our interventions. So our interventions are focused on things like improving communication between partners. And that can address both, in SEBA, for example, addressing communication between partners is something that is protective both for increasing condom use and also for reducing intimate partner violence. So it's the same kind of thing. If you can improve communication between partners, you can address both of these things at the same time. When we talk about culturally tailored methodology, as you'll see as I go over all of the different studies that we have, we tend to use a lot of mixed methods in our work. And from what I've heard this morning, it seems like that's something that's used here as well. So that we use both qualitative and quantitative to inform the two methodologies in the same study really inform each other. And it's valuable in a lot of ways. It's valuable, and here I'm probably preaching to the choir. You all understand this, that when you give a bunch of instruments to people to fill out, the instruments might not be culturally appropriate. They might not really, people may not relate to them very well, so you'll get one kind of set of findings from the quantitative. If you ask the same question in a focus group or in an interview, you might get a very, very different response. The other thing about qualitative research with minority populations that's really powerful is that by saying to your participants, you are our experts, you are the people who can help us understand these problems, you are the people who can help us develop interventions, and it's not just a, it's not just a message, it's the truth. It's very empowering, and it really opens people up to really tell you what's going on in their lives, which is really the knowledge that we need in order to do the intervention, develop the interventions the way they need to be done. We also use community-based participatory research. CBPR, you've probably heard about this. It's sort of a new in thing at NIH, although I don't think they've really figured out what to do with it yet. And the idea with CBPR is that the academic center and the community center are partners. For a long time, there's been community-based research, so academics go out into a community setting and will perform their research there, or will ask the community to help recruit participants, et cetera, to get the word out. But in CBPR, it's really a much more of a parallel process where the two groups, the community and the academic institution, are partners. They're developing the study, they're designing the study together, they're going to conduct the study together, and they're going to disseminate it together. And it really enriches the research. And so that's CBPR, and a little bit later I'll be talking about a project that we've done that is a CBPR project. Other culturally tailored methodologies have to do with recruitment. We really have to be aware of the specific barriers that exist in terms of recruitment. Again, this is not something I have to cue you in on. It's really interesting. I was talking before to somebody about how in other parts of the country where there isn't a large minority population, where there isn't a large Hispanic population, people have no idea that these issues are important. And here we take it for granted that we know that we have to address people's fears, their suspicions, their concerns about what happens if I sign up for anything, what's going to happen to me in terms of documentation issues, et cetera. The realities of life where if you go for a study for a couple of hours, you could lose a day of work, and you could even lose your job. And therefore, we really have to be aware of that and be flexible about how we time our work, the kinds of hours that we offer, the transportation that we offer, the reimbursement that we offer. Obviously, language has to be addressed. And stigma, because we're working in areas of HIV, we're working in areas of substance abuse, of violence. All the areas that we work in, and I think many of the ones that you work in, are stigmatized conditions. And so we have to be very careful so that people can feel that they're going to be in a study and not pointed out and not identified to other people as somebody with a problem that is stigmatized. And this issue of stigma isn't just at the individual level, but also at the community level, because communities are sensitive to being pointed out and stigmatized, et cetera. So they want help, and we want to help, but at the same time, we need to really emphasize strengths so that people don't feel that we're just out there to, point the finger at a community as being a problematic community. Measurement obviously is very important in terms of having culturally appropriate methodologies. We have to make sure that the measures that we use are psychometrically appropriate. The psychometrics make sense, the validity, we can't assume that a measure is reliable and valid for one population that is going to be reliable and valid for another one. So we need to be very careful about that, and of course of how we translate measures. The translations that we have for Miami, for example, may not work for El Paso, because the Spanish, some of the words that we use in Cuban, for example, may not make any sense here for Mexican Americans. And we've had that experience in Miami actually over the years, because when I first started working in Miami 20 years ago, the vast majority of Hispanics were Cuban, and that's no longer true. Now Cubans are only about half of the Hispanic population, and we have a lot of people from Central America and from South America, and some of our words just aren't the same, so we have to pay attention to those kinds of issues. We learned that with working with our friends in Chile as well. Carabinero is a police officer in Chile, and we never heard of that word, but it's an Italian word actually. So, and then in analyses and how we analyze our findings, we need to take into account the cultural factors that may serve as moderators of our outcomes. For example, things like acculturation, things like language that's spoken, even the language in which the measurement was delivered, etc. So that's what we mean by culturally tailored methodologies. And finally, an area that we're moving in much more in this next iteration of our P60 is the idea of implementation science. So that we're focused on culturally tailored interventions, on measuring outcomes, et cetera, of interventions and developing these interventions, et cetera. But the interventions are really of limited value if they stay in an academic setting. The idea is to get them out into the real world and to make interventions that can be feasible and translatable out into the community. And so some interventions are much better suited for that than others. So an intervention that's relatively standardized is much easier to export into the community than one that's very individualized and requires a tremendous amount of training. So that we have to be paying attention to what are the factors that make implementation possible. And so, some of the reasons that interventions don't get out into the community have to do with, really providing the support and the training that's necessary to make sure that things are manualized the way they need to be done. That you have to pay attention to the setting in which you're trying to export it. Centers and community agencies have their own culture that sometimes are amenable and sometimes are not amenable to adopting an intervention. And the science of implementation is really something that's getting a lot of attention. At NIH, for example, the whole translational science approach has become very, very important. And it's something that we need to pay attention with health disparities research, because a lot of times the kinds of community agencies that are serving minority populations are the ones that are absolutely stretched to the limit in terms of fundings and burden, et cetera. And to think that we can take this great intervention that we've developed, this great gift, and we're going to give it to a community agency, they're going to say, thank you very much, we're going to do it, is unrealistic, because really the agencies, you need to be working with the agencies so that what you are giving them in terms of an intervention is something that's feasible for them. and considered of value for them. So in that light, we think of all of our work in terms of falling into these stages of treatment development. So that there are 3 stages of treatment development. This is something that's been for a long time used in the FDA world for the medication development and device implementation, et cetera. And it's really been as well adopted for behavioral interventions. And so the 3 stages are pilot studies. So first there's pre-development, so you're doing basic studies just to understand what are the needs, what are the risk factors, what are the kinds of things you want to address. Then you do pilot studies. Then you actually can do a stage 2 study, which is taking intervention, manualizing it, and doing a randomized trial in sort of a controlled, in a very sort of controlled setting, often delivered by your academic people, and maybe with some kind of restrictive inclusion and exclusion criteria so that you have the most sort of optimal chance for finding outcomes. But then the reality is really stage 3, which is when you take your intervention, take it out into community, all of a sudden you open up the inclusion and exclusion so that so your chances of getting outcomes really become a lot more challenging. And so those are the 3 stages. And up to now, in our first center, which is funded now and for the rest of this year, we've only done through stage 2. And what we've done for this new proposal is actually at stage 3, which I'll talk about briefly. By the way, I'm really happy that we have a full hour to talk about this, which is a luxury. Usually you go to a conference and you have 15 minutes to talk and you have to like speed through everything. So we have, if anybody has any questions or comments, et cetera, as we go along, please feel free. So I'm going to tell you about some of our pre-intervention development studies. In our first round, we were funded to do a pilot studies program so that each year we were able to fund what we called pilot studies, but they actually were developmental studies. And I'll tell you about each of those that we did. So Project Vida, your dean and PI, Dr. Vasquez, was the PI of this project. And Project Vida was focused on men, on Hispanic men, both heterosexual and men who have sex with men, in terms of doing both, and doing a mixed method study that did both quantitative and qualitative research. And the qualitative part was focus groups with men separately, the 2 groups, the heterosexual and the MSM, in terms of understanding how these different health conditions went together for them in terms of substance abuse, partner violence, and mental health issues, and HIV risk behaviors. And Dr. Susantes is going to talk a little bit more about that program of research. And this study it was done with 164 men and has produced several publications and has led to some new studies. Dr. DeSantis has recently been funded to do a study that's a spin-off of this through our university's Developmental Center for AIDS Research, which is funded by the NIH, and has just submitted a grant to the NIH to do something with this. And I understand that Vida is being replicated here in El Paso. And I'm sure it'll be really interesting to see how the 2 groups of men compare, the ones that we have in Miami and the ones here, in terms of these findings. Another study that we did with a PI from our medical school, who's an immunologist, is attitudes about circumcision. So as you probably know, circumcision has been found to be protective against acquiring HIV among men. It's been used quite a bit in Africa, and studies have been pretty much overwhelmingly in favor of showing that it is a protective thing. So Dr. Castro was interested in finding out how we can promote circumcision among Hispanics. In the United States, Hispanics is the group that is least likely to use circumcision. And so Dr. Castro did a study in which he did both qualitative and quantitative methods with Hispanic couples who were expecting a baby to find out what their attitudes were towards circumcision. He also did an associated study where he did similar kinds of work with healthcare providers. Interestingly, what he found out was that the biggest resistance against promoting circumcision or talking about circumcision as an option for families was really among the healthcare workers, not so much about among the parents. So he's been working, he has a, leads a clinic for the Miami-Dade Department of Health with STIs, and has been working on developing an intervention for the healthcare providers in terms of informing them about circumcision, sort of demystifying it, and seeing what the options are. Another study that we did along the same lines, mixed methods, both qualitative and quantitative, was done by a young psychologist in the School of Medicine, the Department of Psychiatry, where she worked with HIV positive Latino adults and did, again, both qualitative and quantitative work in trying to understand the association between health literacy, cultural factors, and neurocognitive functioning and medication adherence. And this was one of those studies where the difference, it was very, very, there was a striking difference in what she found in the quantitative and in the qualitative. In the quantitative measures where she asked people about their HIV adherence, everybody was 100% adherent. Everybody said, I take all my meds all the time. Amazing, right? And then when she got them into the focus groups, and it was interesting because even within the qualitative methods, I think if she had done this as one-on-one interviews, it would have been very different. But in the focus groups, she would have one person sort of say, yeah, well, you know, sometimes I don't take my meds because I forget or because I have to hide them. And all of a sudden, it would be sort of like an effect where everybody else in the group would admit that they're not taking their meds either, and for the same reasons. And so here you had the quantitative findings telling you that everybody's 100% adherent, and the qualitative, which clearly showed that just about everybody, was almost universal in all the groups, people were saying, yeah, there are many times when I don't take my medication for X, Y, Z reasons. The other thing that was very striking that came out in the qualitative findings here were the issue of, you know, our religious institutions are really stigmatizing. They're not supportive. They really are rejecting of people with HIV. And one of the things that we have in Miami, which I think is a little bit different from here, is that we have a large African American population. And the African American churches in Miami have been very, very open to people with HIV. In fact, there are HIV ministries. So churches that people with HIV know that they can go to, and it's not just for them, it's for the larger community, but they know that they'll be welcome, that they're not rejected in any way. And people in Miami who are Hispanic, they see that, and they say, our community is not like that. We have to be hiding who we are. And I would imagine the case is very similar with substance abuse, by the way, where the churches, the African American churches in Miami, have been really open to people with substance abuse and supportive, et cetera. But in terms of the Hispanic community, you don't see that. You really see people who have HIV, who have substance abuse, being socially quite isolated. And this was a message that came out very loud and clear from the participants in this study. And so Maria has been working on a CVPR proposal that's now, I think, hopefully in the second round, was rejected the first time around, but a CVPR proposal to work with religious institutions in Miami-Dade to see how we can find a group of pastors who are open, who are willing to change, you know, to sort of spread the word in terms of openness and lack of stigma and destigmatizing HIV among the Hispanic community. Another project that was mixed methods, which I will be talking about more in detail a little later, is the Partnership for Domestic Violence Prevention. How am I doing for time, by the way? I have 45 minutes?
No, you are talking 45 minutes.
Oh my gosh. Okay, I could talk about this all day. I'm going to sort of skip over this because I'm going to be talking about the PDVP project more in detail. So we have two stage one. So stage one is the pilot studies, and really we haven't done as many pilot studies. The only pilot study that we have to date is one that Dr. Cianelli is doing, where she's piloting an intervention. I'll be talking a little bit, and she'll be talking more about CEPA. And CEPA was the intervention that was developed for Latina women to prevent HIV, to prevent intimate partner violence. The stage 2 study that we did for CEPA only went to age 50. And what we found in the course of doing CEPA was that women over 50, and in fact, some of them were lying about their age. Imagine women over 50 lying about their age. Were saying, you know, in order to become eligible, and they were saying, wait a minute, we need this too. We are having sex, and we are at risk. And so Rosina has been developing an extension of SEPA for older women and is piloting it at this time, and she'll be talking a little bit more about that. We have two stage 2 efficacy studies, and these were funded directly by the P60. The first one is called SIFTA, which is Culturally Informed Family Therapy for Adolescents. Daniel Santisteban has a long history of working with adolescents who are either at risk for substance abuse or already using substances. And what he's done is he's taken structural family therapy that's delivered, that's been found, family therapy is well known in the field as being efficacious for prevention and treatment of substance abuse in adolescents. And what Dan has done is he's created a culturally specific form of structural family therapy that addresses themes that are specific, in addition to the usual issues, addresses themes that are specific to Hispanic families. So one example is immigration-related separations. This is an area that I worked with him on many years ago, where we were doing studies in general of Hispanic youth, and we found that it was not an insignificant proportion of them that were coming to us with problems at age 13, 14, where, after you dug in a little bit, you learned, by the way, my son, my daughter, only came to live with me recently. He was living back home in Ecuador, in San Salvador, wherever it was, for 7 years with my parents, and I finally was able to bring him over, and that happened about a year ago. And yeah, big surprise, we have some problems with our relationship. And it's really interesting when you see families, when they're in the midst of so many problems, these issues that should be sort of obvious, that seem obvious to us, that if you've been separated for 6, 7 years, you're going to have problems in terms of your relationship and with your child, they weren't so obvious to them. These moms, for the most part, they were moms that were here, and they were sacrificing themselves, working 2, 3 jobs, sending money back home. I mean, I know this is something you see every day. And only talking by phone. Sometimes they left their children with their parents and told them, didn't really tell them the truth about what was going on. Yeah, mommy's coming back, mommy's coming back. 6, 7 years later, finally they were able to bring their kids over. And so we developed a module specifically to address these immigration-related separations, which are actually quite common in these groups. So that's one aspect that he addresses. If there has been an immigration-related separation, he has a module to address that. Another one is acculturation differences. So one of the things that happens is that children tend to acculturate more quickly than parents. And so you have the usual difference, generation gap that we see in all families, where as children get older, they start individuating and needing their independence, et cetera, and being more interested in their peers than in their families. But when you have a family with this acculturation issue, where you have 2 different rates of acculturation, children acculturating more quickly than parents, then you have an extra layer of problems, because you have children who are not only becoming adolescents and more independent, but they're more Americanized, which tends to be more independent and more focused on peers. So he has a module specifically to address that. So Dan has an ongoing study. He's enrolled about 145 families out of 200 that he needs to finish the study. And he's looking at kids who are age 12 to 14. And these are kids who are already at risk for substance abuse because of some mental health condition. Maybe they have ADHD, maybe they have depression. And so what he's working on is breaking the trajectory of acquiring substance abuse problems in these families. He also has 2 other studies that use El Centro as a platform, which are funded separately through the NIH. One of them, which he calls SIFTA Tele, is incorporating technology as a way of delivering the intervention. So he's got these little laptops that he's giving to the families where they can access information, where they can get more interaction with the interventionist, with the therapist, etc. And he's also using this study to adapt SIFTA for African American youth. The background that he comes from, and that I come from as well, worked originally with both African American and Hispanic kids. He branched off and made SIFTA specifically for Hispanics, and now what he's doing is creating a version which will probably be a SIFTA for African Americans, and he's using this study to do that. And this is a ARRA, it's what do you call it? The Opportunity Economic Stimulus opportunities that came up, and he got one of those grants. The other one is a major RO1 from NIDA, National Institute on Drug Abuse, that's called SIFTA treatment. And this is the SIFTA intervention developed specifically for kids a little bit older, age 14 to 17, who already have a substance abuse disorder. And he's working in close collaboration with a community treatment provider of substance abuse for this study. The other study, which Rosina is going to talk more about, is CEPA2. And this is a randomized clinical trial, again, funded by the Centro, that enrolled 548 women, Hispanic women, and conducted the CEPA intervention, which is a group intervention created specifically for Latino women to address HIV risk in terms of condom use. And that was the primary focus, but it's also been found to have outcomes for intimate partner violence and for substance abuse. So the study is done. The outcome paper is under review at AG, American Journal of Public Health. And it was an intent to treat analysis, so everybody who was randomized was studied, whether they received the intervention or not. And the outcomes are quite promising. So the women in CEPA compared to women in the waitlist control had decreased rates of chlamydia. They had improved condom use. They had decrease in substance abuse, decrease in intimate partner violence, and they had improved communication with their partner, improved HIV-related knowledge, improved intentions to use condom, reduced barriers to condom use, and community prevention activities, which has to do with to what extent do you go out and talk to other people in your community about HIV. So the impact has been quite good. And as I said, Rosina hopefully will have a chance to talk a little bit more about this one. So finally, I want to talk a little bit about, just very briefly, about two studies that are proposed in our new P60 grant. As I said, we're moving into stage 3. So what we're doing is we're taking two interventions that have been empirically validated, CEPA, which has now been empirically validated here in this study that we did in CEPA2 and had already previously been validated in a study done in Chicago. And we're trying to move it out into a community setting. We're also taking an intervention that I helped to develop, SET, Structural Ecosystems Therapy, which I'll talk about more in the afternoon, and also take it out into the community. And the idea here is to what we're calling translational studies. And these are studies where we're taking the intervention and we're going to have it, whereas in the stage 2 studies, the interventions were delivered by our staff, by our research staff. In the stage 3 study, the interventions are going to be delivered by community agency staff. And in each of these cases, we're doing a limited translational study. We're doing it with one agency. When you really do a true, full-fledged implementation study, you'll do it across 20 sites, 25 sites, whatever, and you'll randomize at the site level. We're doing something much more limited, much more modest, which is to try it out in one place. And we're not only interested in seeing what the outcomes are, but we're also interested in some of the feasibility aspects. So what is treatment in terms of fidelity? How well do the people in the community agencies, with how much training does it take, how much hours does it take of their time, and how close can they get to the fidelity of the intervention, and what is the relationship between fidelity and outcome? So all those issues are really important. If we're really going to take an intervention and send it out and say, okay, it's ready to go out to the community at a sort of a large level, let's try it out first at a more modest level. And finally, I just want to talk briefly about an international study that we have. So we had an opportunity to get an administrative supplement from the NIMHD after the earthquake that happened in Haiti back in 2010, in January 2010. They had a devastating earthquake. I know you all know about it. We had an opportunity to do a supplement, and basically we wanted to do something that was going to be building capacity. There were a lot of people. The University of Miami was extremely involved in delivering services, et cetera, and getting involved as soon as the earthquake happened. There were people on the plane from UM immediately, I mean, literally within hours of the earthquake, and really have done a tremendous amount. But we wanted to do something a little bit different, which was, first of all, not do something in Port-au-Prince itself, which was the most devastated, but was also just inundated with agencies, global health agencies, et cetera. We went to the second city of Haiti, Cap-Haïtien, which is in the northern district, where you had a lot of people who were sort of evacuating from Port-au-Prince and going to Cap-Haïtien. And when we said to some contacts that we had there, we said, okay, so it has to be something in our research portfolio. It has to be HIV or violence or substance abuse or mental health. We thought the first thing they were going to say was, oh yeah, we need HIV help, because everybody thinks Haiti, HIV, et cetera. And what they said to us was, without a doubt, what they needed was mental health. This northern district of Haiti that serves 1 million people, that was serving 1 million people even before the earthquake, and now it had more people because of evacuation, had one mental health provider. Imagine. And the concept of mental health in Haiti is completely different than the concept of mental health that we have in the United States, that Hispanics have. So we really needed to do something that was culturally appropriate. Fortunately, we have a collaborator at University of Miami who is a Haitian psychologist who's developed an intervention. So what we're doing, actually a training program. So what we're doing is that we're training 125 healthcare providers in Cap Haitian, nurses, doctors, social workers, even some more lay people, in terms of being able to identify mental health symptoms in their patients, to be able to triage them, and to do very basic sort of supportive kinds of interventions. We're training 125 people over the course of a year. We've done our first group, which really went super well. They're so appreciative. It's a 1-week training program, and we sort of overbooked it, thinking that there was going to be attrition. There was elections going on at the same time, and we figured there'd be attrition. So we overbooked it. We booked 26 people. All 26 showed up, and all 26 attended every single day. Actually, Rosina is the coordinator of that project, and has been very instrumental in creating all of the relationships with the Ministry of Health, with the hospital, with the medical school, with the nursing school there in Cap Haitian. And the great part of this is that at every training session where you have 25 people, they're identifying 5 people who really get it, who really are passionate about it, who really seem to have a potential for becoming trainers themselves. And they're trained to give the training program, so that by the end of the year, we will have trained 125 healthcare providers in this methodology. But more importantly, we'll have 25 people who are there to then train other people out in the community, so that really this is building capacity. And that's our international program that we have right now. So I took the full hour, I think, but I don't know if we have any time for questions, comments, et cetera. I think we're scheduled for a break.
We do have a few minutes for questions.
Okay. So thank you for your attention, and please. Oh, I don't know. We're very, very excited about collaborating with your center, with your school. We have so many common points of interest. We have 2 very special sites. In Miami, we're sort of a bridge to Latin America. We're a bridge to the Caribbean. And here, you're literally a bridge to Mexico. And so we have so many things in common, and yet 2 unique populations that are similar in some ways and different in some very important ways. So the potential for collaboration, I think, is really just limitless, and we're really excited about that. Yes?
I'm sorry if I missed this. I would like to just ask you something about your fourth focus of the center. There are 4 foci.
Yes.
Substance abuse, family violence, or
So-
something. And
Right.
the 4th is the associated
Yes.
physical and mental. I don't know if I missed it, but are you connecting that to
Yes.
stage 2?
Yes, thank you. Thank you for the opportunity to clarify that. So every single one of our studies really is addressing these multiple issues, and mental health is pretty much an issue in every single one of them. So for example, in the SIFTA program, the program for adolescents, the adolescents who are eligible for the study are adolescents who have a pre-existing mental health condition, for example, like ADHD, like depression. So part of the intervention is also availability of psychiatric consultation for medication, et cetera, for helping the families understand these conditions better. So that's one example of how mental health is integrated. Usually I don't know that we have any studies where mental health is the main outcome, but it's usually one of the outcomes of, really, we probably have a depression measure in every single one of our studies, for example. In terms of other co-occurring conditions, it's an area that we want to get into more. We've had a doctoral student, for example, interested in cervical cancer. So of course there's a great deal of overlap between HIV risk and cervical cancer risk. So that's an area that's really ripe for looking into. We don't have anybody in our school who's an expert on metabolic disorders or on diabetes and overweight, but as we all know, that's a huge health disparity and something that's really ripe for intervention, and that has to some extent, some common underlying substrates to the other issues that we're looking at. So we don't have anybody like that, but that would be an area, for example, that we'd be very interested in. We're always have our eyes open to somebody who's interested in building that into one of our studies. Does that?
Yes, thank you.
Okay.
Actually, you mentioned the two co-occurring, chronic
Yes.
diseases and mental health problems and that area. Thank you.
Okay, so I look forward to talking more, and you'll be hearing more from me later in the day. Thank you.